There is another, we've got some more questions coming. So there is another kind of more specific scenario question, and I encourage any of you to kind of answer as to the best of our ability with the given, data. So I'm going to read through the question. So this is a patient who is ALK positive, I believe stage 4, taking Alcanza or Alectinib for a year. Since January 2022, she has been taking a reduced dose of 900 milligram. On the last CT scan in June, there was a new lesion in the left lung and fluid in the right lung. All other lesions were stable or reduced. A patient went back to full dose of 1200 milligrams, and they made a biopsy of a new formation, passed the NGS for analysis. So the question is, until there is confirmation of the analysis, to stay on Alectinib, or should they add chemotherapy with Pemetrexed in this situation? So I think, initially it seems like patient was started on Alectinib, then there was some dose reduction, and then there was some new lesion in the left lung and fluid in the right lung. So I'm assuming there was some progression, and so the patient went back to the full dose. And it seems like there was a new biopsy done, and that was used for NGS. So I'm guessing the biopsy may have been from the progressive lesion. So the question is, until there is confirmation of the analysis, to stay on Alectinib or to add chemotherapy with Pemetrexed. So I think the question is really asking that there is progression, there is perhaps a new biopsy, which is the NGS is awaited. So what to do while we're waiting for the NGS results, to stay on Alectinib or kind of add chemotherapy with Pemetrexed?
I think depends on the patient, how symptomatic the patient is with the disease progression. The number one thing about oligoprogression is how symptomatic the patient is. Because if the symptoms are not that significant, then we can wait for the NGS analysis, because sometimes, and ALK is less likely. You can find a mechanism of resistance that you can target with other drugs, with other oral drug, as we're learning how to do this, right? Because this wasn't a problem a few years ago when we didn't have that many options. So if the patient is not that symptomatic, I usually wait. If the patient is symptomatic, depends on the symptoms, right? So adding Pemetrexed as adverse events, it can be added to Alectinib or target therapy, because many clinical trials right now are evaluating chemo plus target therapy, and we know it's overall safe. What is not safe is to add the immunotherapy with the TKI as safe. So I think addressing the symptom is very important in this case. If the patient is having recurrent pleural effusions, then yes, we need to start treatment and addressing the pleural effusion. Also, it's important to understand if the symptoms are very bad with the pleural effusions, adding Pemetrexed will not quickly resolve the pleural effusion. So will be two types of approach: address the symptom itself. Do we need a Pleurax catheter? How we're going to address these pleural effusions that are accumulated and making the patient symptomatic, and then adding the chemotherapy when you wait for the NGS. If the patient is not symptomatic, I usually wait, understanding that the wait is around 2 to 3 weeks.